today's lecture, we're going to talk about thoracic trauma. This ongoing series on trauma we're talking about. We're going to talk about thoracic trauma for Tuesday. Also, we'll talk about abdominal trauma. And we'll do further trauma topics as days go on. So, thoracic trauma is a significant form of trauma. Obviously, within our thoracic cavity contains our mediastinum, which has our heart and great vessels. We have our two lungs within our pleural space, and it's designed to be pretty much a closed circuit. So any type of disruption could definitely affect breathing and hemodynamic stability. As you see here in this picture here, it shows a patient that has a sucking chest wound. A sucking chest wound is where you have an external wound, also known as an open pneumothorax. And the treatment for that, which we'll get into further, is an occlusive dressing taped on 3 sides. There is some current literature that recommends, depending on how big the hole is, not doing that. However, the current scope of practice, current standard of care, still recommends using an occlusive dressing taped on 3 sides. And with the patient, that allows for ventilation of air from the inside of the chest externally, thus preventing a tension pneumothorax. These are the objectives we're going to talk about. We're going to talk about major symptoms of thoracic trauma. There's some significant ones we need to know about. We're going to talk about signs of thoracic trauma, and we're going to talk about immediate life-threatening thoracic injuries. The immediate life-threatening thoracic injuries, primarily a tension pneumothorax, performing a needle chest decompression or needle thoracentesis is almost immediately resolving and ultimately life-saving. We're talking about the flailed chest, which is generally described as 2 or more ribs broken into 2 or more places. There are other ways of delineating it, depending on what book you read, but generally that's the one that's widely accepted. We're talking about pathophysiology and management of an open pneumothorax, which is also known as a sucking chest wound. We're talking about hypovolemia and respiratory compromise, because remember, shock is a widespread state of inadequate tissue perfusion, and you have to have intact pump, intact vessels, and enough blood volume with oxygen carrying capacity to maintain homeostatic state. Also, we're going to talk about clinical signs of tension pneumo in conjunction with proper management, which is needle thoracentesis. Okay, thoracic injuries, 20-25% of traumatic deaths involve thoracic injury. Some of them could be direct injury to the heart through penetrating trauma or through massive hemo or pneumothoraces, which uncorrected could lead to cardiovascular compromise and ultimately death. You can ultimately lose all your circulating blood volume in your chest cavity. Potentially fatal thoracic injuries, such as tension pneumothorax. Another one would be a cardiac tamponade in some areas. Some areas, pericardiocentesis is definitely indicated for cardiac tamponade. Okay, our chest wall anatomy. If we look here, we'll see that the chest wall anatomy, we have our ribs. Under our rib, we have all of our nerves and vasculature under there, which we remember from when we talked about needle decompression, and we did one in class. We always talk about our landmarks being between the 2nd and 3rd intercostal space on the midclavicular line, or between the 4th and 5th mid-axillary, going up and over the 3rd rib in the case of the midclavicular route. We notice our trachea is midline. The trachea should never be deviated one side or the other. Also, we see our clavicles, and the clavicles kind of obscure that first rib. So you always want to remember that the first rib runs underneath the clavicle. Up here, I see trachea bifurcates. There's your carina right there. It bifurcates into your right and your left bronchus, your right being more inline than your left. That's why when you intubate, you want to definitely make sure you have good equal lung cells bilaterally, and make sure you have proper tube placement. The right main stem is the most likely place of a tube that's been pushed down too far. We notice here we have the mediastinum, which sits right behind the sternum, contains the heart and great vessels. We also have all of our ribs here, and underneath our ribs we have our pleural space, which we have our 2 lungs. And within our lungs, we have our bronchus, our bronchioles, and then our alveoli, which are the air sacs, which butt up against the pulmonary capillary bed facilitating gas exchange, both the onloading of oxygen and the offloading of CO2, which is very, very important for a long life. So we definitely need that. Ribs, all these structures are designed to be very protective of the vital organs. However, when the chest wall becomes very unstable, it causes a lot of underlying damage. Also, we want to keep in mind too that the right lung has 3 lobes compared to the left lung, which has 2. If you remember that from cardiology. We have our diaphragm, which facilitates breathing. We all know that our respiratory system is a negative pressure system, so the diaphragm has to drop, intercostals have to pull the chest wall out, and their sternocleidomastoid or neck muscles have to pull the chest wall upwards. Thus, negative pressure is created and air goes in. When positive pressure is created, then air will go out. So that's one cycle there. So as you see here on the right side here, you see, like I said, intercostal vessels. You see the ribs, and you see the pleural space. As you see here, how wide that is. If you're going to do a needle decompression, you need to have a needle that's a minimum of 2 inches long and preferably a 14 gauge. Many commercial needle thoracentesis needles are 10 gauges and 12 gauges, and most of them involved a hinged, or not a hinged, but a spring catheter, which is a non-kinking catheter, which will facilitate optimal air removal from the thoracic cavity. Okay. The 2 types of injuries when it comes to chest trauma are fairly simple. You have blunt injuries and penetrating, much like all other trauma. Blunt issues come from direct compressions. We get issues to solid organs. Remember, solid organs will bleed. Blow out of hollow organs would spill their contents. People that tend to bleed tend to go into shock. People that blow out hollow organs, in the case of like the abdominal cavity, tend to have issues with sepsis as days go on. But hollow organs, remember, our lungs are hollow organs as well. And prior to a traumatic event, some people will hold their breath and they'll have that paper bag effect where they actually blow out their lungs, causing a pneumothorax. Plus, we have percentage of people, if you remember back to our pulmonary chapters we talked about, is that if you remember back to our other chapter, remember, a blowout of hollow organs, so they tend to spill their contents. So think of the paper bag effect. Apologize for the brief pause there. This recording is still relatively new to me, and you guys know how much I love technology. So direct compression, deceleration forces, whether it be shearing of organs and blood vessels, that's all blunt trauma. Penetrating trauma is when something goes from the outside through the inside. So it could be a knife wound, it could be a gunshot wound, it could be any type of impaled object. It could be anything like that. It could be glass, it could be anything. So direct trauma to organ and vasculature. Energy transferred from mass and velocity. So remember, mass is how heavy something is, and velocity is how fast that is going. Tissue hypoxia. Shock is a widespread state of inadequate tissue perfusion. So inadequate oxygen delivery, whether it be from impaired pump, impaired blood vessels, or impaired blood volume, lacking oxygen carrying capacity. You may have ventilation perfusion mismatch, which means you can get enough oxygen in, however you don't have enough hemoglobin with oxygen carrying capacity to distribute the oxygen and facilitate CO2 offloading. Pleural pressure changes. Remember, we breathe in a negative pressure system, and ultimately pump failure. If you can't pump blood forward, blood will back up, and that could be either from pump failure or it could be from hemodynamic compromise from a tension pneumothorax. That'll actually put more air into the pleural space that's inside the lung and will cause a shift on that lung, causing pressure onto the pump, thus causing pump failure or inadequate cardiac output. Signs and symptoms. Big ones with signs and symptoms with thoracic trauma is shortness of breath. People have trouble breathing. They may have chest pain. All patients that have had thoracic trauma need to be cardiac monitored. Don't just assume, well, their chest hurts because they were wearing a seatbelt, or their chest hurts because they might have hit the steering wheel. Remember, an object in motion stays in motion until acted upon by another force, so another object. And remember that when the body hits something with 60 miles an hour, their heart hits the inside of their chest wall at the same speed. Hemoptysis is coughing up blood. Cyanosis is the blue color that people get. Circummoral is around the mouth, and acrocyanosis is a blueness of the extremity, and central cyanosis is blueness of the core. Neck vein distension, jugular venous distension. I posted a picture on that on our Facebook group this morning. That's normally caused from back pressure to the venous circulation, either from left ventricular failure or from tension pneumothorax. Tracheodeviation, you tend to see that as a very late sign with a tension pneumothorax. Asymmetrical movement means that the chest wall doesn't move in the same, across the board, doesn't move in the same motion. Chest wall contusion is a large bruise. Open wounds could be lacerations, penetrations, puncture wounds, stab wounds. Subcutaneous emphysema is when you have a buildup of air into the tissues, and that's indicative of a pulmonary insult, especially if you have closed chest trauma. You'll see a lot of subacute emphysema circulating into the chest wall, and you'll see a lot of around the neck. Shock, like I said before, is a widespread state of inadequate tissue perfusion. Tenderness and stability. If it hurts, generally splint things that hurt. When it comes to thoracic trauma, we don't want to restrict the chest as much as possible. We do not want to do that. Tenderness and stability, crepitation, the old tick there. Crepitation is the feeling of bones rubbing together. Instability is the chest wall is supposed to be intact, and it's not. Adventitious lung sounds or breath sounds are abnormal. You might hear a pleural friction rub, which is a sign of the lung rubbing against the pleural space due from decreased surfactant in that area. You also may have pulmonary edema from cardiovascular compromise. You may also have absent lung sounds on an affected side in case of a pneumothorax or diminished breath sounds. It's always important to listen to our lungs and listen to our upper and lower lung fields, upper, lower, and middle lung fields actually, and if at all possible, listen to them from their back, which may be difficult if you're immobilizing these people. However, when you put a patient on their side, we're supposed to inspect down their posterior aspect, and that'd be a perfect opportunity to quickly listen to their lung sounds. The primary survey, we'll talk about the deadly dozen, which is a common thing they talk about, which is composed of airway obstruction, which generally could be corrected, flailed chest, 2 or more ribs broken, 2 or more places, and open pneumothorax or sucking chest wound. Massive hemothorax, which is a big accumulation of blood in the thorax. Tension pneumothorax is a pneumothorax that's under pressure. And cardiac tamponade is where you have the sac surrounding the heart, pericardial sac, that fills with blood, either from the blunt chest trauma causing a myocardial contusion or through a laceration of the heart itself. So cardiac tamponade is basically where the sac around the heart fills with blood and the heart loses its ability to pump effectively, thus will go into cardiac failure. Myocardial contusion. Remember, bruised cardiac muscle doesn't conduct electricity nor contract very well. So we always want to put these patients on a cardiac monitor. A myocardial contusion can mimic a ST segment myocardial infarction. So you may see dysrhythmias, you may see premature ventricular contractions or other ectopy and things like that. Traumatic aortic rupture. A lot of those patients tend not to live for us to see them, but if you can get a patient to a trauma center soon enough and it's a leaking type thing versus a severed aortic rupture, outcome is not very good with that one. Tracheobronchotree injury, excuse me, tracheobronchotree injury involves either a trachea or a bronchial, or bronchus or a bronchial. These things can cause all types of problems. You remember, like with CHF, where you have fluid back up into um, the lungs from the left side of the heart. You can also have similar issues when the lungs fill with blood. So blood will fill those fine air spaces and will actually impede gas exchange. Pulmonary contusion is a massive bruise on the lung or lungs, and those could be very devastating, especially if it damages the vehicular layout, causing problems with gas exchange. And blast injuries due to the shock waves and whatnot can cause major, all these type injuries. Airway obstruction. Secondary hypoxia. So common cause preventable death. So either from foreign body, it could be tongue, it could be aspiration. You should always have suction hooked up and ready to go. You should also have airways set up, and notice I said airways and not intubation. Intubation is a very much appropriate mechanism. However, we want to avoid pre-procedural or peri-procedural hypoxia. So we want to make sure the patient is very well oxygenated prior to intubation attempts, and prior to any airway placement, we want to make sure the patient has adequate saturation and end tidal. So we want to make sure that's taken care of. Airway obstruction, we learn how to clear those with McGill forceps. We know a lot of times you can clear those from just opening the airway. The preferred way to open the airway in trauma patients with suspected C-spine trauma is the modified jaw thrust maneuver. Okay, always want to consider a cervical spine injury, especially if you have injuries to the trachea. You can't clear a C-spine in unresponsive patients. Remember, all unresponsive patients should receive spinal motion restriction. Penetrating chest trauma, it doesn't need spinal motion restriction unless there's direct spinal involvement. So, and actually, penetrating chest trauma tends to do worse when you lay them flat. So unless you have direct spinal involvement, just because someone is stabbed or shot in the chest, doesn't mean they need to be immobilized. A lot of times they do better sitting up, unless you have things that you suspect spinal involvement, such as paralysis or decreased sensation, those type things. Okay, we have a flail chest here, which shows multiple ribs broken in multiple places. What happens here is this section, the flail segment, moves the exact opposite of the rest of the chest wall, called paradoxical motion. So we see there, we see here is the diagram of how the chest wall works with that on inspiration and expiration. So the treatment of flail chest is to stabilize that flail segment. And also remember, the ribs have a lot of vascular underneath the ribs. So we want to stabilize that as good as possible, either by using bulky dressings or having someone hold some pressure on it. In the past, we've done things like we've secured an IV bag to it, which works fairly well. But we definitely want to stabilize the flail segment. So we'll get rid of that paradoxical motion and also allowing for more intact thorax to facilitate better lung expansion, better breathing, and better gas exchange. Okay. Flail chest, if it's a significant flail chest, remember multiple ribs broken in multiple places, that's a high force injury. Therefore, your patient may need ventilatory assistance. They may need intubation or other types of airway management, whether it be iGel or any other blind insertion airway device. We want to stabilize the flail segment. Trauma, a lot of people refer to trauma as a surgeon's disease, meaning that we could do some stabilization, but until that patient gets a surgery or gets to a trauma center that could do definitive trauma care, time is ticking. So remember, the golden hour occurs from time of injury to the time the patient's at definitive care. Okay, so we want to get those patients going. You can start your IVs en route, and depending on how much assistance you have and whatnot. We always want to monitor for pulmonary contusion. Signs you may have pulmonary contusion is adequate air movement with either decreased oxygen saturations upon oxygenation or really out of line and tidal. So where you're getting either air not getting in or CO2 not getting out. We may see pulmonary contusions. Hemothorax is anything you say hema is blood, thorax means chest or chest cavity, is blood in the thorax. So these patients tend to do better sitting upright because blood will settle and air will rise to the top. Pneumothorax, anything you see pneumo means air, so air in the thorax. You have a simple pneumothorax, which is just air entering the pleural space. It could be an open or closed. Open would be like a knife wound from external to internal. A closed might be someone who has spontaneous pneumothoraces, either from blood in their lung or from like that paper bag effect where you hold your breath and a weak spot of your lung blows out. So you can have that. It's not until that pneumothorax develops tension does it become a tension pneumothorax. So open pneumothorax or sucking chest wound, external wound from outside inside. You can also have an internal type of not sucking chest wound, but you can have a simple pneumothorax from the inside. Remember, an open pneumothorax, however, is open from the outside. So air enters pleural space. Ventilation is impaired. Remember, ventilation is the process of moving air in and out. Hypoxia results. All altered mental states are hypoxia or hypoglycemia until proven otherwise. And remember, patients have trauma conditions as a result of medical problems. So, patients that have COPD already or other types of reactive airway disease or congestive heart failure, these patients may do more poorly with this type of injury due to comorbid factors. Open pneumothorax, as you see here, you have a dressing taped a little bit aggressively, but allows for air to leave. If the patient develops signs of a tension pneumothorax, then you want to open that dressing up, allowing that to vent a little bit better. Other types of things they have, we look up here, is called an Asherman chest seal. It was designed by a Navy SEAL. And it basically is occlusive dressing with a whoopee cushion looking thing here that allows air to leave, but not air to be brought back in. It forms a one-way valve. You also have the Vaseline or petroleum gauze that's in your ambulances. And those are best administered by opening the foil package and then putting the gauze against the chest wall while still attached to the foil and taping that down. That works fairly well. But the big thing is close the hole and allow for air to escape. They also make a thing called a hyphen. There's one in our classroom, but it's basically a large tegaderm, and they're used primarily by the military, but they're getting some really good civilian buy-in due to the wars in Afghanistan and Iraq, and also with the insurgence of tactical medicine becoming more of a specialty with the tactical medics. So you're starting to see more military type equipment brought into the civilian world, which is about time it happened actually. So these are things we see. A massive hemothorax. As you see here, you have a lot of blood accumulating in the chest cavity. It could be from pulmonary disruption, from having direct injury to your lung. It could be from lacerating from a vessel, from a rib fracture, that type of stuff. Anxiety and confusion. Remember, anxiety and confusion are hypoxia. You always need to suspect hypoxia. Don't assume, well, you've been in a car wreck, so therefore, you should be anxious. Anxiety and confusion is hypoxia. Neck veins, very important. Flat neck veins mean your volume depleted. Okay, so very rarely will you ever see a flat neck vein due to chest trauma. The only way you'll see that is that the patient's lost so much of their blood volume that the heart's unable to pump hardly anything around. Therefore, neck veins are flat. But any type of increased intrathoracic pressure will put pressure either onto the heart or into the venous circulation, causing jugular venous distension. Your breath sounds will become diminished. The patient, if you do tympany, the patient will have more of a thud sound, um, dull if percussed. Patient may go into shock as a result of inadequate tissue perfusion, meaning oxygenated blood flow to the brain and vital organs. This would be a good time to remind you guys that shock is, like I said, a widespread state of inadequate tissue perfusion, denoted by pump failure, vascular issues, or inadequate volume with oxygen carrying capacity. That a lot of things can cause shock, so we do need to be cognizant to it. Remember, the point of delineation between compensated shock and decompensated shock is the point at which your blood pressure drops. So if you get there and the blood pressure is low, you're already in decompensated shock. Irreversible shock comes as a result of a progressing shock state, whereas you have an organ failure, such as renal failure. So, massive hemothorax, the treatment for this, sit them upright as much as possible, um, get them out of there, um, treat for shock. Could be a little difficult if their blood pressure is low, so you want to put them maybe at a 40-degree angle, 45-degree angle. That will facilitate breathing and also help out with the blood pressure issue. Volume administration. You want to look at their peripheral pulse. Remember, we want their blood pressure to be somewhere between 90 and 100, which is called permissive hypotension. But we also want to look at the pulses too. If the pulse is improving, we note that the shock state is probably resolving. Whenever you have a shock state, remember our baroreceptors in our carotid sense a drop in pressure and will send a message to the brain, which will tell the brain that we have low pressure. So the brain will send out catecholamines in the way of epinephrine and norepinephrine. Norepinephrine causes vasoconstriction. It's predominantly alpha properties. Alpha constricts, beta dilates. Epinephrine is beta properties, affects beta 1 and beta 2. So you'll get some bronchodilation and you'll get increased heart rate. As you resolve the shock state as quickly as possible, the heart rate may come down. One thing remember though is patients only have so much oxygen carrying capacity. So you want to keep their blood pressure within a permissive hypotensive range, 90 to 100. But our goal is not to get it way over 100 because you actually cause increased bleeding, cause decreased clotting factors, and decrease oxygen carrying capacity, and thus making your patients progressively worse and potentially unsalvageable. Monitor for attention hemopneumothorax. So just because someone has a dull thud on percussion doesn't mean that they don't have air and blood in the thoracic cavity. The treatment for that is a needle thoracentesis. If you suspect a hemopneumothorax, you want to go between the second, third intercostal space on the mid-clavicular line and try to avoid the fourth, fifth mid-axillary due to the fact that blood settles and air rises. Okay. Tension pneumothorax, things you see severe difficulty breathing, anxiety. These patients will tell you that they think they're going to die. Tachypnea, tachy means fast, pnea means breathing. Distended neck veins, you have increased pressure on the venous circulation, so the neck veins will pop up. Tracheal deviation is very rare and normally something you see right before they die from a tension pneumothorax. Breath sounds will be diminished, maybe hyperresonant if percussed, providing it's just air. If it's air and blood, it may be hyporesonant. So it just depends on that one, whether it's air or air and blood. And shock with hypotension. Okay. Tension with thorax, high flow oxygen, decompress the affected side. Okay, that is the treatment for it. We want to make sure between the second, third intercostal space on the mid-clavicular line. We want to make sure we don't go too medially or too laterally. We want to make sure we're mid-clavicularly. We want to make sure we decompress the affected side. Respiratory distress may resolve immediately after you do that. Cyanosis might improve. However, tension pneumothorax patients do get blue. They have severe respiratory distress. They may lose a radial pulse because of increased pressure on their heart, and they will have a decreasing level of consciousness. Remember, altered LC is hypoxia, and hypoglycemia is proven otherwise. Therefore, any type of pulmonary impairment can lead to hypoxia. And these are patients that need to get someplace that can put a chest tube in. Don't be afraid to decompress a patient's chest. I know a lot of times these patients will not be unconscious. They'll be talking to you. So don't be afraid to do that. Okay. I'm going to go ahead and pause for a moment, and then we'll come back with the second part of chest trauma.